Just imagine what it would be like if when a patient and family came into the hospital, both an RN and PN sat down together to do the intake assessment. Both of them would be looking for different things, could offer different aspects of care to the nursing care plan. And the PN would see things through a different lens and really help that care plan of care become much more enriching. And then every day, the PN and RN working together could sit down for just 5 minutes at the beginning of the day and decide who is going to do what.
Hey everyone, welcome to the Nursing Insights podcast. My name is Stephanie and I'm a registered nurse practicing in the state of New Jersey. Getting right to it, the state of healthcare right now is tough, to say the least. Let's just say that the nursing shortage does not spark joy. We can sit in that and stew in it for a while, but we can't live in it forever. Things are changing. So join me as your host as I partner with the New Jersey Collaborating Center for Nursing to hear from nurses across the state about their experiences, trials, and triumphs in the nursing profession. Today on the Nursing Insights podcast, we have Dr. Maryann Alexander, visiting professor at Vanderbilt University School of Nursing and the former Chief Officer of Nursing Regulation at the National Council State Boards of Nursing. Dr. Alexander, thank you so much for joining us today.
Well, thank you. It's my pleasure, and thank you for having me.
We have the awesome opportunity today to talk about the licensed practical nurse workforce. Could you tell us a little bit about the LPN workforce in the U.S., about some of the historical context and education?
Sure, absolutely. Well, first of all, I can give you probably the exact number of LPNs in the workforce on this day. I got this off of the National Nursing Database yesterday, and it's updated on a daily basis. There are 922,340 single active licensees in the U.S. More importantly, about 88% of them are actively employed, and about 71% of them are employed full-time. So that is a significant number. However, what we are seeing, if you look at the trends over time, that number, while it fluctuates over the course of the past few years, there has been a dramatic decline in LPNs since 2018, the number employed. So, that is something that we need to focus some efforts on, boosting those numbers, because I think LPNs are going to become more important than ever for the future of healthcare in this country. The median age of LPNs is 50 years old. Now, what's interesting about this, these data come from the National Nursing Workforce Survey. When the survey came out in 2023, the average age of LPNs was 47 years. So there's been a considerable shift in 2 years. So what we think may have happened is during COVID or right after, a lot of LPNs may have went into retirement or took a break from working, and now the older LPNs have come back in and joined the workforce. So the largest number of LPNs are in the 65 and older age group. And you have to give them a lot of credit. I mean, these are extraordinarily dedicated individuals. And, it's worrisome because they have extraordinary knowledge and experience that when they retire, they will bring with them. So that is a little interesting fact about LPNs. 9% of LPNs are males and the rest female. And males are a little bit younger. They fall into that 50 to 54 age category, the largest group of them. 28% of LPNs consider themselves non-binary, and they fall in the younger age group of about 35 to 39. One thing about the LPNs that I always talk about compared to the RNs is the LPN population is much more diverse. So, for example, about 35% of the workforce is diverse. They are non-white. 20% is Black African American, and that is up in the past 2 years from 18% to 20%. The Hispanic population of PNs is about 11%. So diversity is very good in the workforce. We need that. Patients in our country are very diverse, and it's important to have a very diverse PN workforce. Practice settings, they are mostly working in, and this is no surprise, nursing home, extended care, and assisted living. That is number one. 38% of all PNs work in those types of settings. 12% work in hospitals, 10% in home health, 9% in ambulatory care, and then about roughly 15% work in some other areas not listed on the survey. All these data are taken from the National Nursing Workforce survey that was just released in 2025. The most reported position is in geriatrics. The median salary for LPNs is $58,000, and that has risen about 16% since 2015. One thing I think is very important is about how LPNs feel currently about working and practicing in the current state of healthcare. This question was asked in the 2023 survey, and 25% of the PNs that answered the survey said they felt emotionally drained every day. The number is down to 21%. 30% of them said they felt used up every day, and that number is down to 27%. Now, what does that mean? That means that we still have a lot of work to do, but at least the numbers are going in the right direction. So it's getting better, but it's still a call to action for employers that we need to address the mental health of all our nurses, including PNs. One other thing that I want to mention that I think is really important to know about this group of nurses. The survey asked them what their plan was for the next 5 years. And 23% said they plan to leave nursing in the next 5 years. So what are the reasons for that? 52% of the 23% said retirement. So that we kind of can understand given the age group. 42%, however, of that 23% said stress and burnout was their reason for planning on leaving the profession in the next 5 years. 33% said it was because of an extraordinary workload. 30% said it was due to understaffing, and 25% said inadequate salary. So those are some areas that employers can focus on. Same thing that we were saying a couple of years ago after the 2023 survey. They need to have good mental health services to reduce stress and help PNs focus with what is going on in the workforce. But we need to find ways of reducing workload, making sure the staffing is not overburdening for any of our PNs. And of course, salary is always an issue that needs to be addressed.
Especially for the kind of critical work that they're doing out with our patients, out with our communities. Could you tell us a little bit about what it is that LPNs do? Some examples of the work and responsibilities they may be given as they practice.
Sure. Well, I'm going to read you some data that was published in NCSBN's practice analysis. They conduct that every 3 years and helps them prepare the NCLEX, but also it is very good data for us to know what PNs are doing. And while they surveyed nurses who were in their first year of practice, the one important thing is to know is all PNs do this, but sometimes the amounts shift after they become more experienced. But these are the areas that they're working in. Safety and infection control. They administer medication and monitoring of patients, and that includes parental therapies. They provide comfort to patients and assistance with the performing of ADLs. They provide care that assists with promoting and supporting the emotional, mental, and social well-being of the patient. They reduce the potential for patients to develop complications or health problems related to treatment, procedures, or existing conditions. And they participate in providing care for patients with acute, chronic, or life-threatening physical health conditions. So those are broad categories, and they do a lot of tasks and have a lot of responsibilities that fall under that.
And can you share with us, Dr. Alexander, what does it take to qualify to do this kind of work? What type of educational requirements and clinical requirements are there out there for the LPN workforce?
Sure. So most LPNs go to a program that is 1 year or a little under, and they receive a certificate. And the most current data says about 82% of them receive a practical or vocational nursing certificate. About 10% receive a diploma. 6% receive an associate degree. And about 1.2% receive a baccalaureate degree. So most widely is the year program or year 9 months to a year that offers the certificate in practical nursing.
I didn't realize the variety of education options that one may have to join the LPN workforce. That's fascinating. And is there any data about the cost of getting into the workforce?
You know what? That can vary widely, depending on if you go to a community college or a for-profit school. There's a wide range in terms of what you will pay for an education.
So in relation to patient assessment and delegation in nursing, in New Jersey, the Nurse Practice Act states that RNs shall not delegate physical, psychological, and social assessment of the patient. Dr. Alexander, is this standard practice in other states as well?
Well, it varies from state to state. 40 states address what can be delegated to an LPN, but I don't know every one of those states or what they say. I do know many states say the PNs can only do a focused assessment and not the overall assessment of the patient. And we know that they are taught to do an entire physical assessment of that patient, and I'm sure they're taught to do a psychological and emotional well-being assessment as well. We brought in, when I was at NCSBN, we brought in some experts from education and practice and long-term care, and we asked them, what type of assessment are PNs doing? And they consistently, across the board, said that they are taught to do full assessments, and they are competent to do full assessments, and in many places they are doing full assessments.
So to be able to understand a bit more about the workforce and how the workforce is changing and evolving, could you tell us a little bit about the role of LPNs in patient assessment, the delegation part of nursing, and kind of what the standard practice may be for where LPNs fall into that?
Well, you know what? That is a hard question for me to answer because that is all over the map. So every Nurse Practice Act handles that differently from what an RN can delegate to them and also what they can delegate to someone else. So one of the things you mentioned, assessment, there's a huge variation there. From a lot of practice acts say they can only do a focused assessment, while others say they can do a more broad general assessment. We know LPNs are taught in school to assess the entire patient, both their mental and physical well-being. So that is something they are competent to do, but it is up to the practice acts to include that. One of the things that I can tell you is when I was at NCSBN, I was working with regulators from around the country to update what NCSBN has called a Model Nurse Practice Act. And it is just a guide for states when they want to update their practice act or look at kind of what the model is. And we brought in individuals who were educators and from long-term care and different aspects of practice. And everyone was in agreement that an LPN can do an entire assessment. So the focus assessment really needs to be revisited because it's hard for anybody to walk in a patient room and only look at maybe the wound they're changing and not look at the entire patient and be able to assess their lungs if they're having trouble breathing or whatever the issues they might identify.
And I think that's really the way that healthcare is aiming to direct itself as well, which is looking at a person as a whole person. We know that we are not segmented or isolated creatures in any part of our system. We are entire holistic beings.
Exactly.
And one of the other pieces, I guess, for myself and for our listeners, I know you were saying that different states are setting up their practice acts in one way, but the actual licensure part of being an LPN is a national exam, is it not?
Yes. Every LPN in this country takes the National Council State Boards of Nursing PN NCLEX exam.
I think it's very interesting that each of the states have their own way to regulate and enact the work that their LPNs will be doing, while we know everybody is being held to the same standard through the PN NCLEX.
Correct.
We are talking a little bit more also about enhancing the LPN role. Can you walk us through some of the recommendations that were published in the April 2022 editorial, the Journal of Nursing Regulation Steps to Strengthen the LPN Role in the Current Healthcare Crisis?
Right. And I'll take responsibility for these because it was my recommendations. But one of the things that I think needs to be done, and I mentioned a little bit about this, is the role needs to be reviewed. And by that, I mean not just by educators or regulators or practitioners, but by everyone, including policymakers, and really be updated so that education, practice, and regulation is all in alignment. We expect all nurses to work up to the level of their education, and some of the practice acts are a little bit behind. So I think that a group is needed to come together to really look at the LPN-VN role and then make recommendations. State nursing practice acts should be updated according to those recommendations. Then hospitals, nursing homes, and all types of settings should align the practice of PNs with those recommendations. They need to be considered important members of the healthcare team. They really are vital parts of our healthcare system, and we could use them more than what we're doing. We need to fund new PN programs because one of the things I said earlier was we're seeing a decrease in the number of PNs. And part of that is we're not seeing the dramatic growth in PN programs like we see for RNs. So we need more PN programs. We probably need to market that role a little bit more so people want to become a practical nurse. And employers should be offering a tuition assistance to practical nurses so they can go on and become RNs, and we have a pipeline of nurses coming in. So one of the things that I suggest in my article is a new model of care. And I suggest that hospitals, if we have enough, we can't take away from long-term care, but if we have enough practical nurses, we can have a new model of care that really helps the RNs do their work and makes patient care safer. And that is what I would call a primary care team. So the team would be a practical nurse and an RN that works together. And not like with team nursing, where the RN supervised and had very little participation or hands-on care. This would be a model where the RN worked alongside the PN in providing hands-on care to the patient. But just imagine what it would be like if when a patient and family came into the hospital, both an RN and PN sat down together to do the intake assessment. Both of them would be looking for different things, could offer different aspects of care to the nursing care plan. And the PN would see things through a different lens and really help that care plan of care become much more enriching. And then every day, the PN and RN working together could sit down for just 5 minutes at the beginning of the day and decide who is going to do what. So a friend of mine, she is a nurse, her mother was just in the hospital with cardiac issues. And excellent outcome. She had a stent placed in her heart. It went very well. She's doing very well. But what did my friend remember? The fact that she went to see her mother at 2:00 in the afternoon and her mother had not gotten out of bed yet. And when she requested that her mother be gotten out of bed and walking more, the RN said, and by the way, she said they were extraordinarily hardworking and they were extremely competent. But the RN said, I am so sorry, but I don't have the time for that. We don't have the resources to be getting the patient up even twice a day to help them walk. So missed care not only is documented as a cause of complications for a patient in the hospital, but also it is often what patients remember about their hospital stay. So even when they have great outcomes, they say it took 30 minutes for somebody to bring me my pain medication. It took a long time for someone to answer a call light. No one walked me all of one day. Those are the types of things that if you had this LPN and RN partnership could get done more readily. It would relieve a lot of the burden on the RNs and it would be more eyes on the patient. I would be willing to bet you it would reduce complications and thereby cost, even though it seems like a costly model. If a patient isn't trying to get out of bed themselves, if they can put on a call light and have somebody answer it sooner, there may be less falls and the costs and complications related to that. And I think that there will be much more satisfaction on the part of both PNs, RNs, and patients if you have a model like that.
What it really sounds like you're describing is an allyship, a real, like you said, partnership between the RNs and the LPNs. And I know this might be a bit of a spicy take, but I think it's been discussed frequently that sometimes there's a lot of headbutting that happens between different groups of our nursing profession. And I've seen that happen while I was growing up in my nursing career, this kind of, tension that sometimes arises with the bachelor's prepared nurses and LPNs. And I'm curious if you could frame for us, somewhat in the way you did, a bit of how an allyship would benefit the nursing workforce as a whole. Because there's historically, a good amount of tension I've seen, in my practice, there's a good amount of tension between the two groups, but it really needs to be reframed as a way that both groups can support each other because we're all nursing colleagues and allies here in this space.
Right. I want to say, get over it. We should be helping one another and working together and not have that type of tension or be concerned that somebody is stepping on our toes.
That reflects so much. When I was in nursing school, I had understandably so, really emphasized to me that this is your bachelor's preparation program. You are, so qualified because of this and this. And I believe that, absolutely. When I went into my first nursing job, I was given the opportunity to work alongside these super experienced, super competent LPNs that were making my daily life so much better as a colleague and as a new nurse to be able to learn from them. And I really feel strongly about the point that you're making, that there is so much that can be done in terms of partnership to help the entire nursing workforce there.
Right. It's all about teamwork and collegiality, collaboration. Those are all the essence of leadership, which we expect all our nurses to have, those leadership skills. And it would just benefit everyone. It would make everyone's jobs more enjoyable and would lessen the burden on everyone. And I think it would make care safer.
Absolutely. And what is the secret sauce behind the LPN workforce? We know that there's so much opportunity to engage and to appreciate and to empower our LPN workforce, and really understanding, you had said, for employers, for our communities, like what can be done to help them shine? How do we help differentiate them? How do we help elevate and lift up their practice?
You know, to me, if you have them work to the full extent of their education, if you pay them the salary commensurate with the work that they're doing, if you provide adequate resources for them to do their job, provide mental health services, all of that, whether you are a PN or an RN or whatever, that elevates your work. That makes you want to do a great job. I'm not sure they have any special needs compared to anybody else in healthcare. I think that's something that every nurse deserves.
Absolutely, and 100%. And I think one of the things that you brought up early in the conversation is how special the LPN workforce is in terms of diversity and in terms of being able to really draw from a variety of backgrounds, of demographics to make the nursing workforce, because in some ways it's more accessible to get into. So would you be able to talk to us a little bit about why our LPN workforce has such a variety of characteristics?
It could be because it is a stepping stone. You know, you can do it for less money. It's less time. If people have a lot of family commitments, they're not committing themselves to 2 years, as it would be at least in a nursing program. But I don't know if we've ever really examined why people become an LPN versus an RN. But here's one of the things. The numbers are dwindling. And part of that could be the RN role is becoming more enticing. In fact, the Bureau of Labor Statistics says that because of the low wages, the less responsibility, the less autonomy, that more people want to become RNs.
Do you see, Dr. Alexander, a future in which LPNs are dwindling and what that effect might look like on our health systems or for our nursing workforce?
Well, I can tell you this. If LPNs go away, so will long-term care. Because right now, they are the mainstay of long-term care and assisted living. And without LPNs, those facilities would not be able to exist.
That makes 100% sense. As I've worked in different care settings, and it's true, LPNs have such a level of responsibility in those settings and are so prevalent in terms of making sure that healthcare is delivered.
Right. People have suggested maybe we should phase out that role, and I have strongly advocated that we need that role because of their expertise in geriatrics and taking care of the older patient.
And with our population as it is on the aging increase, it's such a critical space of need.
We're going to need them more than ever.
Absolutely. In New Jersey, we're starting to have many acute care hospitals hiring LPNs. Could you talk about the trend of having LPNs in acute care settings and whether it's happening nationwide or just here in New Jersey?
That's a good question, because I have heard that there are an increasing number of LPNs going into hospitals and hospitals considering opening their doors to them. But I looked at the data, and right now, the data is not showing that. It's still long-term care that has the biggest number of LPNs. And over the past couple years, I have not seen a trend in the direction of hospitals. But it may be more prevalent in some states than others. I was looking at national data.
And speaking of national data, when we talk about nursing and the nursing workforce nationally, would you happen to know what % of our nursing workforce is made up of LPNs?
Yes, I would say about 20%.
So a significant number.
Yeah, so there are about, now these are rough numbers. There's about 5 million nurses total, LPNs and PNs, and then close to 1 million PNs. So that's about 20%.
Which is a huge proportion.
Yeah.
And you had shared that a significant amount of that proportion is also looking at retiring or leaving the workforce coming up in the next few years.
Right.
And I love the point that you made that what we need in order to help protect and support our nurses is the same that we need for all of our healthcare professionals, which is really something that we need to continue to do, is advocate for mental health, advocate for compensation, and for the safe and well-supplied work environment that everybody needs to have to support good care.
Exactly.
So Dr. Alexander, could you share with us a little bit about the historical context of LPNs?
Sure. Well, just to clarify, I am not a nurse historian, and you could hold a whole course on this topic, but it's very interesting because I did look into it. And really, the PN role dates back to the 1800s. And in 1892, we saw the first class for formal training of a practical nurse emerge. And when you start to see education programs, that starts to give a foundation for formalizing a profession. So in 1892, the YWCA had a class for formal training, and that was followed in 1893 by the Ballard School for Practical Nursing opening. In 1914, Mississippi was the first state to pass a law to license practical nurses. Interestingly enough, it took until 1960 for every state to have a nurse licensure law. And you can see why practice acts can differ when they are put together and developed and enacted over such a long period of time. From 1920 to 1940, practical nursing was limited to home health visits and public health, and they played an important role in prevention and infection control. In World War II, we started to see the expansion of that role. So we saw PNs in clinics, in health departments, and hospitals. They were very active during both of the wars. And then in 1941, another kind of key sign that a profession is really becoming strong is the National Association for Practical Nurse Education and Service was established. In 1944, we started to see the tasks of an LPN become defined. A comprehensive study of practical nursing was conducted by the U.S. Department of Vocational Education. And then in 1949, the National Federation of LPNs organized a joint committee on practical nurses and auxiliary workers, and they recommended the title Licensed Practical Nurse. And they differentiated the tasks between RNs and PNs. In 1961, the NLN began accrediting nursing programs, and then it becomes very interesting. After World War II, there was a shortage of nurses, and as you know, oftentimes in a shortage is when we see a change in a model. And what everyone decided at that time was that RNs were a scarce commodity. And so they thought that RNs could be better used as supervisors and having PNs do the hands-on care, and probably some nurse aides do the care, and the RN would be the supervisor of the care. And at that time, the hands-on care provided by an RN was reduced from 70% in 1941 down to 30 to 60% in 1951. So that was team nursing. But in the 1980s, we saw the emergence of primary care. And then it was very much the hands-on care was provided by the RNs. And that's where we start to see the PNs leaving the hospital setting. And in the 1990s, really becoming the mainstay of long-term care.
What a rich history. I did not realize the level, all of the elements that come together to create the workforce as we have it today. And even now it continues to evolve.
And there's much more.
Mm-hmm.
There's much more. I've kind of tried to cut it down to some major occurrences, major events that happened that really impacted the evolution of the profession.
That's amazing. We talked a little bit about how there are LPNs who do transition into the RN workforce. Would you be able to talk a little bit about maybe what percentages come through the pipeline of LPN to RN, or how is it frequent, or is that something we should be able to support LPNs in more, or we should aim to support LPNs in more? Could you just talk to us a little bit about the role of transitioning LPNs to RNs?
I do not know the exact number, but it is not as high as we would like to have a rich pipeline from the LPN role into the RN. And I think we need more incentives for that. So we need more mentoring of LPNs by RNs. That's something that model of care that I suggest would do, where if the RN could mentor the LPN and encourage them to move on in their education. We need more tuition reimbursement, and we need more assistance overall to help individuals continue their education, such as even issues like daycare. That can be a real obstacle for people that want to continue their education. We need to do more to help, especially some of our minority and disadvantaged groups that have a lot of obstacles in their way, to relieve some of those burdens to help them continue their education.
And you had mentioned before having things like the employer reimbursement of tuition expenses and such. So all of that can really help propel those who are interested in continuing forward with their education.
Correct. Yes.
We do have one question that we ask every nurse that comes onto our podcast, and that is, we know that the nursing profession is very giving, and at the same time, we also need to take care of ourselves. So Dr. Alexander, could you tell us what it is that you do to take care of yourself at the end of the day?
Oh, well, I have a hobby that I really enjoy. I play the violin, and I think that music is a great way of, at the end of the day, just being able to relax and absorb yourself in something different, that's very different from what you did all day long. And I enjoy walking and hiking and doing things outdoors, but I live in Chicago, and you can't always go outside with our Chicago weather. So the violin is a great way that I can just relax and think about something very different.
Amazing. Thank you so much for sharing of your expertise, Dr. Alexander. We appreciate having you on the podcast today, and we are so grateful for the work you do for our workforce.
Thank you for having me.
Thanks for listening, everyone. We'll see you next time on the Nursing Insights podcast.